Hello everyone. So today we are going to talk about another topic in the clinical bacteriology of the microbiology. One of the most important topic, that is leprosy. The leprosy, we also called it as Hansen disease. The leprosy is caused by the Mycobacterium leprae, and the Mycobacterium leprae, we all know the Mycobacterium leprae is acid fast bacilli. So what is the chief clinical features of the leprosy? So the clinical features of the leprosy is that we see a hypopigmented anesthetic lesion, or we see the hypopigmented anesthetic patch in our various parts of the body. We can also see the thickened earlobe, and we can also see if nerve are involvement. Then we see the glove and stocking type of the loss of sensation, or we can see the glove and stocking pattern of the anesthesia. We see if the nerves are involved. So these are the main clinical features of the leprosy. So how we diagnose the leprosy? We diagnose leprosy by the skin biopsy. We take the skin biopsy from the hyperpigmented lesion, or we take the skin biopsy of the from the suspected lesion, or we take it also from the earlobes, or we also do the tissue polymerase chain reaction. From these two investigation, the leprosy can be confirmed. Or we can also do the culture of the uh, Mycobacterium leprae bacilli. This can be done in the 9-banded armadillos. Now let us move towards the classification of the leprosy. There are mainly two classifications that we are using. So one is WHO classification of the leprosy, that helps to um, provide or prescribe the anti-leprotic medication, and we also classify it as Ridley and Joplin classification. In this Ridley and Joplin classification, the severity of leprosy is identified. So the WHO classification, mainly it is divided into paucibacillary and multibacillary. I want to describe in short, in brief, about the paucibacillary and multibacillary. The hyperpigmented lesions are mainly of less than 5, and in the multibacillary it is more than 5. That means the lesions 1 to 5 of the leprosy comes under the paucibacillary, whereas the lesion more than 5 comes under the multibacillary. So now moving towards the Ridley and Joplin classification, it can be divided into lepromatous leprosy, borderline leprosy, borderline lepromatous leprosy, the borderline tuberculoid, borderline tuberculoid and tuberculoid leprosy. If we talk about the lepromatous leprosy, the lepromatous leprosy presents as diffusely over the skin with Lionel-like faces and is communicable. That means the patient with the lepromatous leprosy has the high bacterial load, and it is characterized by the low cell-mediated immunity with the highly T helper cell 2 response. So lepromatous leprosy can be very dangerous. But if we look at the tuberculoid leprosy, the tuberculoid leprosy is limited to the few hypostatic lesions, and hairless skin plaques can be present, and it is characterized by the high cell mediated immunity with the highly T helper 1 cell response and low bacterial load. That means there are two poles of the leprosy in the Ridley and Joplin classification. That one is lepromatous leprosy, which is highly infectious and the person has low cell mediated immunity, and another is the tuberculoid leprosy that has few hypostatic lesion and characterized by the high cell mediated immunity with the low bacterial load. So now let us move towards the multi-drug therapy of the leprosy. That means anti-leprotic drugs, various anti-leprotic drugs. First of all, let us talk about the patient with multibacillary leprosy. So the course of the multibacillary leprosy is like 12 months. We give the rifampicin 600 mg. I am saying this for the adult. The child dose is calculated and given accordingly, but this is the adult dose of the leprosy. The multibacillary leprosy is, if there is presence of multibacillary leprosy, then it is given for 12 months. The course of duration of the multibacillary therapy is 12 months. Here we give the rifampicin 600 mg once a month supervised, and the dapsone is 100 mg daily self-administered by the patient. And we also give clofazimine. The clofazimine 300 mg once a month is given under the supervision, but the patient has to take 50 mg daily by the self-administration. So again, in the multibacillary leprosy, in the leprosy treatment, the multibacillary leprosy is treated for 12 months. The rifampicin is given 600 mg once a month under the supervision of the clinician. The dapsone is given 100 mg to the patient. It is daily self-administered, and the clofazimine is given 300 mg once a month under the supervision, and 50 mg daily by the self-administration by the patient. Now let us move towards the paucibacillary leprosy. The duration of course of treatment for paucibacillary leprosy is 6 months. Here we give the rifampicin 600 mg once a month under the supervision, and dapsone 100 mg daily under the self-administration by the patient. So these are the treatment for the multibacillary leprosy and the paucibacillary leprosy. As I have told, the child dose is calculated and given according to the weight of the child. So this much for today. I hope you understood this topic on the Mycobacterium leprae and the leprosy. Thank you.